with my introduction. It gives me great honor that we were able to get someone who is sought after all over in the world. Now, the fun fact is that this is home to her. So Chris is a graduate of our program. She's going to tell you all about it. I'm not going to tell you, but she's a Molloy alum. And the fact that she can talk to us about the work she's done, I'm hoping people will be so inspired and have the ceiling raised of what Molloy is capable of, because we produced me. I'll take credit for her. And we gave her, you know, she asked me, what should I do, Ronnie? What's the audience going to be? And I said, we're mixed. You don't take out the data for sure. It's not an undergraduate class. But I also said that I wanted her to talk more personally. So we gave this the title of Building a Program of Research in Symptom Management. And that's where we're going with that one. And Chris, I will bring you up to your first slide. And Dr. Christine Miaskowski.
Thank you. Great to be here. You know, as Ronnie said, I am a graduate. June 4th, it'll be 45 years. Now, my dear friend Bob Kimpointner, who's chairing the English department here, would say I owe all my success to going through hell with him. And there's probably some truth to that. 30 years ago, Monday, I defended my Ph.D. And I realized that on Tuesday when I was at the Rockefeller giving their Renfield lecture. And I do have to say, I'll share, I had Bob edit my PhD. His comment to me was, it would be a great novel, except it has no plot. So there you have it. We'll talk a little bit about that. But Ronnie did ask me to do some conversation around how I came to do what I do, as well as talk about some of our science. So I took a little bit of snippets from our work. And I'm really, really open to you guys asking me anything you want, all right? I've been doing this for, what, almost 40 years now, so. But I forget, you asked me this, what drives the work I do, all right? So to me, the kind of work we do at UCSF, and I am one of a large team of people, is driven by caring for patients. And I'm going to share a case with you, all right? So I want to introduce you to Frank. Frank is a 65-year-old man, retired recently, avid gardener, has a beautiful lawn, and has a putting green in his backyard. His wife, Helen, notices that his voice was becoming hoarse in May of 1976. He had an ENT consult. He was diagnosed with laryngeal cancer. He had radiation, recurred, went through and had a radical head and neck. In 1977, as he was starting to learn esophageal speech, he had another recurrence. He was left with severe headaches and severe neck pain. I taught his wife how to administer morphine, and Frank died in intractable pain. I still choke up on that. That's my father. Okay, that's me on my first communion day. All right, that's what led me to begin to do symptom management work. And you'll see some of our early work was really around pain, and it's gone and developed since then. So I was asked by Ronnie to talk a little bit about how do you build a program of research. So I'm going to tell you my rules, all right? They're my rules. You can ask me anything you want about these rules, or you may have other rules that we can talk about. But for me, it has to be about passion. Right? If you are journeying and starting your dissertation, pick something you love, right? That you really have an intellectual curiosity about, that you want to understand. Because this is a tough job, right? It's a really tough job. It's a lot of work. Patty's shaking her head, right? It's not the same kind of work as taking care of patients on a daily basis where we get immediate gratification. This is more challenging to keep the momentum going. So you have to love the idea of discovery. I'm going to show you my federal grant trajectory. What's made that successful, I believe, is I made a promise to myself that I would never ask a question that wasn't clinically relevant. Now, I've done things that are somewhat esoteric, and even some of the stuff we're doing now, people accuse me of being a little bit esoteric. But I can see the application into the future, into how it's going to make a difference for patients. And if you're going to write a federal grant, that first section after the specific aims is significance. The idea, the way I always write that section is, why should the feds give me whatever amount of money I'm asking for? And I think that's true whether you write a $1,000 grant or you write what we just did was a $23 million grant. You've got to demonstrate why somebody's money is worthy of being spent on your investigation. I get a sense from the way Ronnie's leading this program that I don't have to talk about networking and mentoring. And just in the brief conversations we've had, I hear you're going outside of the faculty at Molloy to bring people in. And that's the future. That really is the future, interacting with different disciplines. And I'll share with you some of the groups that we work with at UCSF. This is really important. People ask me, how do you sleep? I do sleep. I actually require a lot of sleep. But trying to juggle things and utilize things over and over again. One of the biggest challenges I think PhD students have is they take a course, they do A. Yeah. They take another course, they do B. And they start all over again. Well, A should travel over to B. And you should be using things over and over again as you move through the program, and that helps. I'm going to talk a little bit about this notion of having a vision within the current study. When I get to the list of grants, I'm going to wait and give you an example for that, but it really helps. And the caveat is, a grant is not a contract, right? You are not, if you put in for a small sigma theta tau grant, an American Nurses Association grant, a federal grant, grants mean you can have some adaptation in that project. You have to answer the questions, but you can add to it. Nobody's ever going to fault you for doing that. And I'll give you an example of that when I show you some of the work that we've been doing. This is another one that's really hard. I hate getting reviews back. I hate revising an article or a grant more than I do writing the original, because it's a pain in the butt. My piece of advice for you, and this is what I do when I work with my faculty at UCSF, is share the news. Do not put this in a drawer by yourself. Pretty intimidating, but for people that are successful, and I think UCSF is a pretty successful place, there's a community of trust that's established. We share our summary statements with everybody and have people read them, because I read them very defensively with a very, very different lens than Ronnie would read them or Patty would read them and say, Chris, did you think about this? Did you think about that? Really not an easy thing to do at first, because you're kind of, oh, I don't want to show they said all these bad things about me or they didn't get what I wrote. But really, that makes a better and stronger application. And I'm going to come back to this. Ooh, I told you, I warned you. I warned you about that. You did. I'm going to come back to the dissemination thing at the end of the talk. Okay? All right, so how did I get to be where I am? And I want you to remember this talk. This is about 40 years of work, right? Maybe 30, because I was a clinician for 15 years. I worked at Albert Einstein in the Bronx after I graduated from Molloy. So I actually toyed with going to medical school. And I tell you that because it was one of the best decisions I ever made not to. I realized I do terrible on standardized tests. You know, the MCAT, disaster, absolute disaster. And I applied 3 times. That's how determined I was. I spent a lot of money. And then I realized I really like being a nurse. I don't want to be a doctor. I really don't. And at the time, so this was 84, 85, there weren't too many choices to get a PhD in New York. You went to Columbia for an EDD, which I didn't want to do at the time. And no offense to anybody from NYU here, but Martha was there with her crystals. Okay? For those of you in the room that know that, all right? I didn't want to go there. I did not want to do crystals. So I said to myself, and I didn't, for family circumstances, I couldn't leave the area. I lived in Mineola. So I said, okay, I'm going to, and I heard, do any of you know Barbara Hansen? I'll tell you this as an aside, because this is about mentoring. So Barbara Hansen was a professor at University of Washington. A little bit of a thing, okay? Powerhouse lady. And I got my master's at Adelphi. And they had a speaker series there, and Barbara came. And this was when I was toying around with the Ph.D. and what was I going to do. And she's up on the podium talking about, she is the nurse that got Ross Labs to make Ensure. And her Ph.D. was in physiology. And she's up on the podium, thank God we're not having lunch, and she's talking about trying to create a diarrhea scale to study tube feedings in monkeys. Okay, she's up there babbling away, blah, 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 blah. And then she says, and this was the part that was most impressive to me, she did a randomized control trial in human beings. And the patients had to serve as their own control. And she stood there and she said, by the fourth patient, I knew what I found in the monkeys happened in humans. And it was the lactose intolerance in tube feedings. And she stood there and she said, I had this huge ethical dilemma. Should I put the rest of the patients through it to get the sample size she needed, right? And she came to the decision, yes, she had to. And I remember walking up to her and saying to her, I want to be a physiologist like you. Okay, so fast forward to this part. I did my PhD at St. John's. I did it in, you see it here, in a lab that was interested in oxytocin and vasopressin, got that done. And then this was 87, March 25th, 1987. I defended. Postdocs were pretty rare in nursing at that time. But Robert Wood Johnson had a fellowship program. And I wrote to get the application. But the week after I finished my dissertation, this is why I'm telling you about Dr. Hansen. A week after I defended my dissertation, I had to go to Washington, D.C. to do a poster, right, in a meeting called the Federation for the American Society of Experimental Biology. 15,000 people go to that meeting. I'm there on a Tuesday afternoon in the neurology section. And literally the abstracts for that meeting were the size of the New York phone book. Okay, they used to print them on newsprint. And I'm looking through, and the next section over is nutrition posters. And Barbara had moved to become provost, I think, of the University of Maryland. And I see this thing, B. Hansen, University of Maryland, some monkey thing about nutrition. I said, it's got to be the same lady, right? So I go walking down the aisle, and I remember a little bit blonde, really petite woman. She's standing there. And I go up to her and I say, Dr. Hansen, I said, you don't know me, but I heard you speak at Adelphi. You inspired me to get my PhD in physiology, right? And I want you to know I did that last week. And she says to me, so what are you going to do now? So this is the punchline. This is about mentoring, right? I said, well, you know, I'm thinking about this Robert Wood Johnson Clinical Nurse Scholars Program. She looks me in the eye and she says, Chris, I'm on the board that selects the postdocs. I got in, okay? And the rest is history, all right? You could go to one of three places. You go to the University of Pennsylvania, the University of Rochester in New York, or the University of California, San Francisco. And I wanted to go back to do pain after my dad. And probably the three best preclinical scientists in the world at the time doing pain research were at UCSF, and I got chosen to go there. So I worked in a rat lab with a wonderful mentor who's now one of my dearest colleagues, John Levine, and I did opioid pharmacology. I looked at drugs that we don't have to give to people yet, but I looked to see, did they relieve pain? And more importantly, if you put them together in combinations, did you get better analgesic effects with fewer side effects? And that's what we demonstrated with that work. So it's pretty cool, pretty cool. Then what, right? Well, they offered me a job at UCSF. And I really wanted to keep a rat lab. They actually built me a rat lab. I could have done that. But when I started on the faculty in '94, began that work, started to think about clinical work as well. And in 1994, they made me department chair. And you couldn't do it. You could not run a big academic department and keep a rat lab. So I said, okay, I can live vicariously through John and his experiments down in his lab, and began to focus on clinical work. I guess if I were to summarize my program, it's really about trying to understand what happens in terms of pain and other symptoms in patients. And our work has largely been in cancer patients or survivors. We've done a little bit in family caregivers. And I can tell you, our caregivers are sicker sometimes than our patients. They're trying to understand that milieu, and I'll show you a little bit of data about that. We've done intervention studies. They are hard. They are really, really hard to do, particularly when you don't have the fundamental descriptive work. But that's a sampling of what we've done. And I'm going to talk a little bit specifically about the grants that we've had. Our newer work, and I'm going to show you some examples of that as part of this talk, is really to look at multiple co-occurring symptoms. And I'll give you the rationale for that as I move through this presentation. And we've become really, really interested in molecular mechanisms. That's not easy either. So if you have questions about that, I can help field some of those or guide you. But it's a journey. It's a real, real journey. And I love to learn. So the mechanistic thing is really, really important to me. Do you have any questions about that? Anybody online? Or I'm happy to answer anything before we talk about some of the specific projects we've done. Or,
Talia?
yeah, please.
I'm just wondering if you're going to come back to talk a little bit more about time management.
Yeah, we can do that toward the end. Sure. Yeah, write your questions out. We can talk about time management some more. Sure. Yeah. I'll just briefly tell you, my favorite person in the whole world is Winston Churchill.
Okay.
I think he's a phenomenal man. Winston Churchill wrote 1,000 words a day.
Okay.
It's very hard to do, I can tell you, because I've tried, and then I've gotten all bowled up, like I keep a log. And does it count if you revise something? We can go there, but yeah, we'll talk about time management. All right, so let me tell you what's been funded, and what I'm hoping is going to get funded. I'll know next Tuesday, actually. All right, so the first study we actually did, and I think this is a good example too of things for people who are starting out to consider. When I came to UCSF, there were 2 other faculty doing cancer research, and one of them was Mary Lynn Dodd. And Mary Lynn's research was around self-care, Dorothy Orum's theory of self-care. And she developed an intervention model called the Pro-Self program. So it was a model to allow patients to be educated by nurses. And you not only gave them didactic information, but you gave them skills training and coaching, all right? So we thought we could take that model, and they had done work in mucositis, no, they had done work in multiple symptoms, and then we were moving to mucositis, oral mucositis that comes from chemotherapy. We thought, beautiful model, been tested, we can do it in cancer patients and adapt it. Well, the feds weren't going to give me $2.7 million out of the chute to do that. So one of the best things I did while we were waiting for this was we did a very large descriptive correlational study. It was the first one to actually look at cancer pain in the outpatient setting, because most of it had been done in hospitals. I wrote 15 papers off of that study of about 500 patients. And I know I've had conversations with some of you about big data mining. That's a wonderful, wonderful opportunity to be able to use that kind of information to build the next larger study. So these projects represent the fruits of doing smaller work. And I'll come back to the main point about all of this at the end of the talk. I've got a slide that I talk about as my Catholic guilt slide. All right. I want you to notice another thing about this slide, and this is part of the success that people don't talk about. I want you to know the dates of these grants. Do you notice anything about those dates as you look down the list?
No.
They overlap. All right. Yeah. Because what happens with these large grants is you get the opportunity to hire people. And you want to keep those people because you've trained them up to be your project director or your research nurses or whatever. So starting small and then building the program. So this study, pain, fatigue, sleep disturbance, was done in radiation therapy. It was in some ways a very good learning study. We were trying to understand changes in symptom over time in people getting radiated, but we also wanted to study family caregivers. So we recruited dyads for this study. And I'm going to show you some of the data from this study. We're still mining this data, all right, because of some of the value of the longitudinal analysis. And I don't know how God inspired me at the time, but I can say it in this institution, and I say it publicly. We collected blood on these patients and their caregivers. Way before it was fashionable to do that, we banked it for genetic analysis. Yeah, who knew? I mean, God love us, we did it, okay? Now, I want to show you, so let me go to this one, and I'm going to come back to this one. So this improving cancer pain management through self-care came from this study, all right, because you want to do a follow-up. So one of the things you have to do when you want to get more money from the feds is say, what did I do wrong? What did I do wrong? All right. So in the first study, we did a control group and an intervention group. And we got a nice effect. Pain scores went down. Patients took more pain medication, which was the goal of the study. But I'm like, I want to do this some more. I knew this wasn't quite right. All right. So we had a standard care group and a control group, a standard care group and an intervention group. Well, when we looked at the intervention group, only 50% of the patients got a clinically meaningful reduction in their pain intensity scores. It's called a responder analysis. Well, how do you think I felt about that? Not good. But the cool thing is you get to figure out why, all right? And in this first study, we had the presence of mind. Again, the feds didn't pay us to do this. We tape recorded all the interactions between the patients and the nurses. And we went back, and I'm not a qualitative researcher. I don't do that. But I hired somebody. We got another grant. Feds paid us because we did such a good job collecting the data, give us more money to analyze it. And we found out in the 50% of patients who didn't get a clinically meaningful response, why they didn't get it. Want to guess?
Fidelity to the intervention.
No, it wasn't. We kept pretty good track of that, okay? We wrote a paper called Pain Autobiographies. Right? And one group did not want any side effects from the medications. They had had enough, okay? And we didn't do as good a job with side effects in that grant, so we knew we could do that better. One group had had a horrific experience with someone in their family who had been addicted. And they weren't going to put these medications in their body. And then the third group, I think, may be unique to California. They didn't want to put anything bad in their body. They had no previous history, but they just didn't want to do it. And so the hypothesis we had in the second grant was, if we gave the patients a stronger dose of the medication, would we indeed get a better therapeutic effect? And we just finished analyzing all that data for a variety of reasons that I'm not going to go into. The dose response didn't work. We actually gave double the dose of the original intervention, then we doubled that. There's no dose response effect. At about 5 weeks, everybody did great. So that's good. We know we don't have to spend a whole lot of money. And we got a therapeutic effect. So that's kind of cool. That's how you build a story, all right? It was really hard to do that dose response. Yeah.
Breaking my own rule.
Sure. No.
You had asked earlier, too, of a pre-pain.
Right. We got baseline pain on these people.
The baseline pain.
Yeah, we did.
So pre-pain wasn't what was maybe changing what.
No, and randomization worked. The two groups had the same level of pain walking in. Yeah. I should tell you, for this study, they all had bone mets. This study was multiple pain problems. Okay. Now, this is my example of building another study into a study to get more money. Right? So this is, you can tell I'm a little bit greedy about this, maybe a little too much. All right, so now this symptom management after breast cancer surgery was driven by work I did here in New York. When I worked at Albert Einstein in the Bronx, I worked with a wonderful neurologist, Ron Kanner, who's now at North Shore. And Ron and I set up a pain service. And on Friday afternoons, we would see pain patients, which probably was a mistake, to be quite honest with you. They're very intense patients to see. And I will go to my grave remembering this woman who came into our office. And this is while I was working on my Ph.D. And she walked in like this. She could not move her right arm. And she sat there. She was the last appointment on Friday afternoon. And she told us a story about how she had been hospitalized 3 times as a postmenopausal crazy woman because nobody believed she had pain under her breast and in her axilla as a post-surgical pain syndrome. She haunted me. She haunted me as I was at UCSF, and I said, we have to study this problem. Okay, and that's what this grant was about. We enroll people prior to starting surgery. We have 453 women in that study. We followed them as part of the grant for 1 year. And the idea was to figure out who gets this problem, what's the trajectory look like, can we understand predictors. Now here's the idea of building another project into a study. It occurred to me, all right, at the time, now there's since been work done, but at the time, no one had done a prospective evaluation of lymphedema. Nobody. Nobody had baseline data prior to surgery. Okay, so this was 2003. So we decided, we bought the equipment, we had some discretionary money, we bought the equipment and we added subjective and objective measures of lymphedema to that study. The feds didn't care, the NCI didn't care that we were doing that, we were still answering the pain questions, right? And I will be quite honest with you, after we added those because we wanted to get the study up and running, I actually read more of the literature about lymphedema. Right? I knew enough as an oncology nurse. Well, you know what I learned? The average time to onset of lymphedema is 14 months. Well, guess what? We were stopping this at 12. Well, an opportunity. Okay. Okay, we wrote another grant. And we were good stewards. We said to the NCI, we said, we were good stewards of your money. We added another measure, look what we found. Certainly you don't want us to miss an opportunity, right? Let's follow these patients out. And lo and behold, we got another 5 million, okay? So do you see the idea?
Yeah.
Sometimes if you're doing your dissertation, this can seem overwhelming, but adding another questionnaire for some additional information. I have never had patients say, I don't want to fill out your booklet once they sign up. They may tell us before it's too much, but once they're in the study, they pretty much stay with us and are nurtured in the process. We have very, very good retention rates in our studies. And then this is some of our current work. I'm not going to talk about symptom clusters. Well, I'm going to talk a little bit about symptom clusters, but from a different study. Here's another example. We were funded to do a really deep dive of chemotherapy-induced neuropathy. So some patients who get chemotherapy get drugs that are toxic to the nervous system. They can't feel their hands, they can't feel their feet, and it hadn't been well characterized. So we got money to do a cross-sectional study with that. We happened in that study to ask a couple of questions about hearing loss and tinnitus. And for those of you that don't know the cancer milieu, hearing loss and tinnitus with these neurotoxic drugs are typically talked about in kids, because in children, they push these drugs to paralysis, so the kids can have severe neurotoxicity, not only peripheral nervous system, but hearing and tinnitus issues. Head and neck, because in head and neck cancer, they radiate and give chemo in the audiovestibular area. In our study, we had mostly women with breast cancer, patients with lung, patients with GI malignancies, and women with GYN cancers. And we added a couple of questions about hearing loss and tinnitus. My medical oncologist, when I went back to them and told them that across all 4 diagnoses, 40% of the patients reported hearing loss or tinnitus, they said, we never ask about that. I said, yes, look at the data. Okay, here it is. And it wasn't always related to the neuropathy in the sensory system. So pretty interesting, right? We said to the feds, we did a good job here, okay? Let us get some more money, and they gave it to us. The good news about the hearing loss, we think, I'm not an audiology person at all, but I've got audiology people on my team, is that the hearing loss is probably amenable to hearing aids. So if we can document this, all of the patients in this study get, or they're survivors actually, all of them get their audiogram, and we tell them if it's abnormal and that they need follow-up. So we're doing really good diligence in that arena. We have a grant that I will know about Tuesday, which, if we get funded, will be $23 million to study these 2 problems prospectively.
Tell them how long you've been waiting, because I want to have a sense of when you submitted it and now you're.
All right, so do I have a moment to diverge to the politics
Please
of this?
do.
Okay. So this is a grant. This is what's called a so just to give you a frame, all of these are R01s, all right? So individual, separate topic. A program project grant, what makes it unique is it's 3 R01s. So 3 of these plus core support, depending on what the projects are. It's been 2.5 years in the making, and let me tell you the politics of this. This is not trivial. Now, I've been funded by the NCI, you can see, a lot. Okay, so they know my name, all right? So this is it's probably, if I get this will be the pinnacle of my career, in truth. Projects 1 and 2 are clinical and they're linked. We have to recruit over 750-ish patients prior to them being exposed to chemo. Project 1 is going to do the sensory stuff, so the hands and feet issues. Project 2, in the same patients prospectively, we're going to do audiovestibular toxicity. So we're going to do hearing loss, tinnitus, and balance problems, because nobody really knows with these patients is their balance problems because they can't feel their feet, or because of the audiovestibular system, or both. All right, so we're going to follow the patients for a year. We're going to meet them in the infusion unit every time they get a chemotherapy infusion, measure all our stuff, and then bring them in baseline 1 month, 3 months, 6 months, 9 months, and 12 months for a full bore assessment and audiogram. And the idea is to figure out who gets these problems. So what are the phenotypic risk factors? What are the molecular risk factors that predict occurrence? When does it occur? Which problem occurs before the other one? Those are the first 2 projects. Back to my mentor from my postdoc, John Levine, and I have been working together. John is going to do the preclinical correlative science in rodents. All right, I'm going to tell you a cool story, just as a little aside. So the framework for the grant, I hate theoretical frameworks. Okay, when I was hired at UCSF, because I had physiology as my degree, I told Mary Lynn Dodd, who was my boss at the time, that I would never teach a nursing theory course. You can have me teach anything else, I wouldn't teach a nursing theory. But every one of these blooming grants has to have a theoretical framework. So our theoretical framework is, you laugh. I can tell you this, I'm an honest person. I usually get somebody else to write the theoretical framework. But this one is stress. And let me tell you the cool animal experiment, okay? Because we're interested in stress and resilience. So John did a preclinical, and we know from our 2 correlational studies, these survivors have a lot of stress. We know the patients have a lot of stress, right? But John wants to work out the mechanism. How does stress induce these symptoms, right? So the way you stress a rodent pre-adulthood is you take them away from their mom. All right, so you birth the pups. Now let's be I can't manipulate the HPE axis in a human, so we have to refer these little rodents who we take very good care of. All right. So John did the experiment where birth pups, he took a bunch away from their moms, and the other pups, they did a resilience protocol. So in addition to leaving them with their moms, they love them more. So you pick them up, just like people. They like to be hugged, they like to be stroked, they like to be loved, put back with the mom. All right, he let the animals grow up. Now, these are all inbred strains. So in a normal experiment, every rodent would get neuropathy, everyone. Right? In the resilient group, they didn't get neuropathy. But it's a sexually dimorphic response. So which sex, because it's not gender, it's sex in a rodent, which ones didn't get neuropathy? You got a 50-50 chance. No, the boys didn't get neuropathy. So, and it is known in humans that women are more likely to get neuropathy from the neurotoxic drugs than men. But John will be able to work that out in the rodent. So here's the politics. We got the best score on the second submission of this grant.
Tell the score.
We got a 2. Wow. Which is for a program project. Okay.
Lower the better.
Lower the only time in your life you want a low score.
You want a low score.
You want a low score. And they don't give 1s for program projects, right? And we've negotiated the price tag back and forth probably 4 or 5 times. This is an expensive study, okay, $23 million. And because we got the molecular work, we got all the patients, right? 3 weeks ago, we got a call from the people we work with saying the higher ups at NCI said, we're not funding this. Okay. The maximum we will give for a program project total cost is $15 million. And I said, that's not enough. We can't do the work. Okay. But then I got annoyed. I got pissed. So when I get pissed, it's not a good thing. So it turns out, this is out of the National Cancer Institute, it turns out that the guy who is second in command at the NIH is a man by the name of Larry Tabak. And he reports to Francis Collins. He's the head of the NIH. And I know Larry from a bunch of work that I did. Larry used to be head of the Dental Institute. And John's appointment is in the School of Dentistry. That's where he's an MD, but he does MD, PhD, but he does his work in dentistry. So I wrote Larry an email, and I said, here's the situation. Here's basically how they screwed us, and this is what I want. I said, it costs 23. They're willing to give us 15. Can the director of the NIH give us 8? And he wrote back. I wrote that email on a Thursday. The following Sunday, he wrote back. He said, you'll hear from the NCI in a week. Took him a week and a half, and we're going to talk to them on next Tuesday. I think we're going to get the money. But it shows you the politic of this organization.
Negotiating the price tag.
Yeah. It's I'm not going to negotiate. They're going to give us 23. They're not going to give us anything because
Why would you take
it's
20?
not okay. No, I'm not going to take 20 because we can't do it. We've already cut it
Interesting.
50%.
And again, I'm breaking my own rule,
please.
but you always end up with, and you get it back, you write something up, and they're going to give you a fraction.
Right.
And we're so used to saying, okay, fine. We're so used to that. And if it costs that to do it, which you have to do a budget. I mean, they have no idea what budgets look like,
right.
but when you're doing that kind of budget, you're down to the details.
Yeah,
And,
no, you have to provide a
yeah,
really serious budget justification.
Yeah.
So we'll see. I'll let Ronnie know if we get the money.
That'd be great.
Tuesday
I'll send that
at
word.
7 a.m. my time. We'll figure out this. There's another little wrinkle in this. I am on the short list to be named to the National Cancer Advisory Board, which actually is a presidential appointment. So there may be some effect from that, but we'll see. That's another whole story we could talk about another time. All right, so how are we doing for time? Any questions on the remote?
We're good.
Anybody have to unmute? You're trying to talk? Can you talk? No, I can't talk. Any questions anybody have?
Do a question
For
here,
this
and I'll
point?
see if anybody wants to unmute. Anybody here want to ask?
In all of those years, all that pain research, anything on placebo effect? What's the status
Yeah.
on that now?
We haven't done it, okay? But there's a lot of work on placebos now. And a lot of work where the science has shifted a lot is to active placebos. Excuse me. So where you go in and you say to a patient, you're getting a placebo, and they work, even though the patient knows it's an active placebo. And I can remember as a nurse, okay, this is terrible. We used to have Tylenol, purple capsules, and we would go around, and if they were ordered and patients wanted something, we would give it to them and say, this is going to help you feel better. They slept, so there is a truth in a placebo, for sure. Absolutely.
I worked at Sloan Kettering
Oh, yeah.
in pediatrics
Yeah.
when the nurses had to administer placebos, and it was pretty horrible. And it's funny how things come back years and years later. But sometimes it did work. But
That's true.
all of us hated to do it.
Yeah.
Every single one of us.
See, I always talk about a therapeutic placebo. Okay, there's been experiments done where, and you may know this, where you go in and you say, here's your pain medication, and you walk out as a nurse. Or you go in and you say, I'm giving you a very strong analgesic. It's going to take effect in about 20 minutes. You're going to feel a lot better. You're going to be able to go to sleep. You know who gets a better response? The person that gets the education, where you're, in a sense, giving them an active placebo. Yeah. Yes?
Question,
Mhm.
and I hope I'm not too ignorant with this,
That's okay.
but
No,
is
any
the
question.
physiology of pain well understood?
I think if I had to answer that, I would say we know more about acute pain than we do about chronic pain. And the reason for that is because most of the animal models are acute. Right? Pull, withdrawal, heat,
Right.
whatever.
Right.
Chronic pain is really complicated.
It's very complicated.
And-
So is the physiology behind that well
No,
understood?
it's bits and pieces.
Yeah.
And, what we know in animals, I mean, the reason we don't have any medicines to treat this neuropathic pain stuff is every mechanism they've found in a rodent and seen a therapeutic response with an agent for a neurotransmitter or a site has not worked in a human being. And in humans, it's probably much, much more complicated in terms of the mechanisms that have occurred. And I don't think back pain has probably the same mechanism as chemotherapy-induced neuropathy. And even in neuropathy, it's probably dependent on the chemotherapy they give. So we got, now there's a lot of work now being promoted through the opioid epidemic to try to study pain. And a lot of the movement is around biosignatures. That's the new term. People thought it was going to be all genes. No. And what was interesting to me, there's been a couple of webinars about these biosignatures and how the feds are viewing biosignatures, both from the NIH as well as from the FDA. Because in order to have a valid biosignature to use to get a drug approved, there's got to be rigorous controls on it. And you can go to the FDA website. There actually are definitions of the different kinds of biomarkers they accept. What was most gratifying to me, I guess is probably the right word, when they talked about the biosignature movement within this federal initiative to fund grants to study chronic pain and opioid addiction, they included patient characteristics and self-report parameters. And I thought they were just going to stay with the, you know, the genome, the gene expression, the metabolome. So it's bigger than that. And I think anybody that's starting to look at big data, artificial intelligence, predictive modeling, it's much more than just the biology. It's stress, it's adaptation, it's resilience, it's coping. It's all the stuff that nursing does. Right? And I often say when I give talks like this, I said this at the Rockefeller, we are the best phenotypers in the world. And we should be sitting at the table. Because the molecular biologists that I work with, or the bioinformaticians, they don't have a clue. Okay, but we need them. We need their tools. We need their power. I'm working with a group in the UK right now where we're doing machine learning to study symptom clusters. These people don't know a symptom from a hole in the wall. What they actually do is, and you know, they know it from their own human experience, but they have no idea. But they are systems engineers, and their major work is getting the traffic lights to work better in London because they study how the traffic moves. But they can make me maps of symptoms that I have no idea. And the joy is you sit at the table with these people and they give you this beautiful picture and they get so excited when I say, oh, I can see this relationship and this relationship. But I couldn't do those analyses. I don't have those skills. I mean, it's pretty amazing when you think about it. So
just click in the middle and you'll go away. Click in the middle. Just use the cursor, the mouse. Click in the middle and you'll know in the middle of your slide.
Oh, in the middle of your slide.
Okay.
All right, so you want to hear a little science? Any other questions? Did I answer your question?
Yes, you did. Thank you.
We're going to hopefully get more out of those HEAL initiatives. I'm hopeful. I am hopeful. All right. So for those of you that don't do symptom science, let me give you a quick overview, and then I'll talk about a few of our findings. And all of what I'm saying here has been published, so you can look at it. We're really interested in, as a side, trying to understand biomarkers for a couple of reasons. We think we can help identify risk, right? Who's at greater risk? And really in a prediction type model. Because of my background in physiology and the people I hang out with, it should also give us some clues about mechanism. And then if we can figure out the mechanism, maybe we can find a target. And I want to make a point about biomarkers. Lots of times when I give talks about our work in biomarkers, I end up talking about the harm markers, the markers that make a worse scenario. Keep in mind that the protective markers are equally important because people who are protected with a molecular marker, that might be a therapeutic site to target. So you got to kind of weigh the two. To get funded, you have to say about the bad things. All right. To get, you have to show there's a case that something's bad. But afterwards, you can think about the good things too. But if you're going to write a grant, you got to say why it's really bad and you got to help people. Okay. So most of the work in symptom science, and I think this is still true and it's needed, particularly across multiple chronic conditions, is we study a single symptom. We study pain, we study fatigue, and that's some of the work I'm going to show you today. I'm going to use fatigue as a model. Reductionistic approach is really, really important. You've got to figure out the background of this symptom, the epidemiology, its characteristics, and there's lots to do in trying to define the characteristic of the symptom. And not unimportantly, how does this symptom impact the patient? either in terms of its occurrence, its severity, its distress. But I've never seen a cancer patient with one symptom. And I believe that's true of every chronic condition we study. So work is being done, and I'm proud to say, taking some of the lead in this area, trying to understand multiple co-occurring symptoms. And I'll show you a little bit of that work as we move through the talk. So what we have found in our work, and this makes the docs crazy, is that patients experience multiple symptoms. And in most of our work, it is independent of the diagnosis or the stage of disease. And that makes the physicians crazy. It makes them crazy because they always think people with metastatic disease, people in the palliative care are going to be worse. Nah, not true. Our approach, and this has been learned, and I'll show you some of the instruments that we use, is we like to study common, what we call kind of common core symptoms, and then cancer-specific symptoms. And we've spent a lot of time picking our measures, and I'm loath to change measures. And I would, encourage you guys to think, are there collective measures you want to use across studies? Because I think what we're missing in symptom science, if that's an area you want to work on, is cancer, in my view, has taken the lead. And probably the next diagnosis that's got a pretty good symptom repertoire, at least in terms of fundamental symptoms, is HIV. But the world's pretty barren in terms of lung disease, heart disease, GI disease. So thinking through that to build programs and getting common measures, if I were starting my career, one of the goals would be to see some of the things we observe, are they true across all chronic conditions? So that's something we need to think about. We've been interested not only in cross-sectional assessments. I'm going to show you some of our longitudinal data. That's hard to do. Longitudinal studies are hard to do, but they're really, really needed. Another thing I lose sleep over at night is thinking about what's the best dimension of a symptom to study. Is it enough to get an occurrence? Should we study severity? Should we study distress? And that's driven by my clinical observations that two people can tell me they have pain, and one tells me their pain score is 1 on a 0 to 10 scale, but their distress is a 10. And another patient can tell me their pain score is a 10 in intensity, and their distress score is a 1. Those are not the same things. And how do we sort that out? And I'm still trying to figure that out. But we're working with those engineers in the UK, and I showed a little data Tuesday night that is helping us. And I really do believe we need to begin to think about inter-individual differences in people's experience as well as symptom clusters, and I hope I can make that point. So this is one of the things we tend to try to study, and that grant we got funded to do symptom clusters really was one that drove this question. So the thing we try to sort out is, and I'm going to use fatigue as an example. Okay, you have 100 patients sitting in an area, they're all going to get chemotherapy. I know from clinical practice that some patients will go through, they'll have no fatigue. You get people who have moderate levels of fatigue, and then people who have horrific levels of fatigue. So that's one of the questions when the patient says to me, how's my fatigue going to be? That's one of the things we're trying to understand with a bunch of symptoms, right? And let me talk a little bit about one of the approaches that we're taking. So this is one of the things you learn in graduate school, in research. You want to reduce variability, right? You set up the experiment, you do inclusion, exclusion criteria, you get the design just right, everything's great, right? That is not clinical practice. Variability is the rule rather than the exception. And the amount of inter-individual variability is huge. And the example I use is the 30% rule. And it's particularly true in things like diabetic neuropathy or postherpetic neuralgia. Every analgesic that's been tried to treat diabetic neuropathy or postherpetic neuralgia, everyone across meta-analyses, reduces pain by 30%, but only works in 30% of the people. So what is that about? That's about subtypes of individuals and what's going on. And it screws us up in terms of, excuse my language, in terms of running a trial, because we don't have sophisticated phenotypes for individuals. So we're really kind of at the basement here, trying to understand inter-individual variability. And as I said before, it's for risk profiling, it's to determine optimal treatment, and then maybe mechanism, which would be great. Okay, so how do we look at this? And I thank God every day that our patients are willing to fill out our questionnaires and to give us blood. So we take a pretty comprehensive approach. If you look at this slide, we do a lot of stuff with phenotypic characteristics. So we get standard demographics. We review the medical records for clinical disease and treatment characteristics. And I bolded those in red to remind me to tell you very often they don't predict the symptom experience, particularly the disease and treatment. We're interested in stress. We're interested in coping. So we get some of those measures. We've done personality in some of our studies. We've done hope. There's a wide array of molecular characteristics. I invested a fair amount of money doing the gene work. We're now moving to do more around gene expression and epigenetics. For those of you that don't know epigenetics, that's how the environment influences our experience. And it's typically characterized with DNA methylation. And some of you may have heard about telomeres. That's another epigenetic one. But importantly, it's not just enough to catalog these. How do these make a difference in people's lives? So we're often interested in patient-reported outcomes. And these are the ones that are common in oncology. The docs really care about survival. We're much more interested in the ones that are nurse-driven. Okay, so some people always ask me, people often ask me, what are the measures we use? So these are the ones we typically use when we're interested in a single symptom. We often give all of them to the patients, and they fill them out for us, and they fill them out over time. So for pain, we use a body map. We use the brief pain inventory. Pain qualities is the pain burning, stinging, tingling, electric, that type of thing. It's a well-validated instrument. We really like for fatigue, if anybody's interested in that, an instrument that was developed by a faculty member at UCSF. It's called the Lee Fatigue Scale. It's short. It's 13 items. 8 are fatigue, 5 are energy. Really easy for people to use. And Kathy did her work in pregnant women and shift workers. So she told us when we started to study cancer patients, because this is the same instrument, you get fatigue and energy, to do diurnal variability. So we say to people, tell us, rate the scale 30 minutes before you go to bed, and 30 minutes, did you need to?
Diurnal variability. That's
good. Or 30 minutes before you get up. Yeah, 30 minutes after you get up in the morning. And I'll tell you, it's different. Really, really, really different. And energy is not fatigue. I can tell you that, all right? We use Kathy's sleep disturbance instrument, the general sleep disturbance scale, but this is also another popular one across chronic conditions, the Pittsburgh's Sleep Quality Index. It's got some peculiarities to it. We like the Center for Epidemiological Depression scale to study depression because it's short and it doesn't have a lot of somatic symptoms in it, which would confound pain, it would confound energy, it would confound a lot of other things. And the other thing is it's got nice normative data in the general population. Anxiety, we use the Spielberger. And then this is a measure of cognitive function. It's called the Attentional Function Index. We've been experimenting with a couple of others, and I don't have the data yet to tell you if they work better or not. We're actually doing a iPad-y kind of measure now, too, which is the patients don't like it, I can tell you. And I have a feeling this is going to be better. So I talked about the genomic markers. Okay, so I'm gonna show you some data from the same study, but 2 different analytic approaches. One is on a single symptom called fatigue, and I know there's some of you here that are interested in how to analyze longitudinal data. So I'm going to show you the approach that we're using. I really like it. And then I'll show you how we're integrating the genomics into those longitudinal analyses. And then I've been scratching my head for a long time trying to understand how can we study the genetics of symptom clusters. So I'll show you our soiree into doing that. And I think it's pretty good. We got pretty good feedback on the paper when it was submitted. All right. So fatigue is the most common symptom reported by oncology patients. It used to be pain, so I got very upset when people started to study fatigue. All right? And you can see, back to my point about individual variability, wide range. Right? So this goes back to that fatigue, pain, and sleep study I showed you in individuals getting radiation. We recruited patients and family caregivers prior to radiation, and then we followed them. And I think I have the timeline in just a second. One of the hardest things about this study was that when we went to do the genetics, we had to combine the patient and family caregiver data because we didn't have enough. And I'll just tell you as an anecdote, all right? This was about 250 patients, 250 patients and caregivers. But we recruited patients who were going to have radiation for breast cancer, prostate cancer, lung cancer, and brain tumors. Big mistake to recruit patients who are going to have brain tumor radiation. They did not do too well filling out our questionnaires, and I'm surprised the reviewers didn't tell us that when we sent the grant in. Lung was difficult to recruit too because they're pretty sick. The interesting thing about prostate cancer, the men with prostate cancer, we had no trouble getting their wives. They actually signed their husband up for the study. Right? We had the most difficult time getting the partners of the women with breast cancer. They protected their partner, usually husbands, but they protected their partner. So we got this dynamic thing going on. When we went to publish these data, we combined the patients and the caregivers. I cannot tell you how many times they said, how can you combine the two groups to study fatigue? There was no difference in the fatigue scores between the patients and the cancer, patients and the family caregiver. And I would write back and say, you know, God wouldn't make a ton of mechanisms to create fatigue. The trigger might be, but the biology is probably different. They're the same at the cellular level. So if you read any of the papers that are published on this study, we have quite a few of them, you'll see this very long explanation for why we put the patients and the caregivers together. That's why we had to pacify the reviewers. Okay, so there's a lot of reasons we can get fatigue. One of them primary hypotheses were cytokines are released. And I think on the next slide I give you the definition of cytokine. Those of you that know. So these are chemicals. They're chemical mediators, basically, that we make in the body. They're really, really important for cell-to-cell signaling. I'm bastardizing all the research on cytokines by saying there's pro-inflammatory, there's anti-inflammatory. I mean, that's stretching it quite a bit for the biologists in the room. There are some that do both, depending on the underlying processes going on. But in general, people will tell you IL-6 is an inflammatory cytokine, TNF is an inflammatory cytokine, and IL13 is an anti-inflammatory. So they're kind of important to think about in relationship to producing fatigue. And there had been preclinical studies and clinical studies drawing serum levels of these cytokines and showing people with higher serum levels of IL-6 had worse fatigue. So we said, let's look at some genomic markers, right? Now, I don't know how many of you know about genomics, so let me give you like a 1-minute class, all right? So this was our first foray into trying to understand genetic markers for symptoms. We were one of the first groups out there to do this. There were serum levels, but trying to actually do a genetic marker. So we started with candidate genes. And within candidate genes, we took specific locations on those genes that are called SNPs. SNPs stand for a single nucleotide polymorphism. So think about them as an address, okay, basically. And I showed you that IL-6 has strong preclinical evidence. We said, well, let's look at, based on the literature, a SNP, single SNP at a location. And the old way that they used to name SNPs, which is this, IL-6 C6101, was based on, if it's a minus, how many base pairs from the promoter was it upstream. All right, so this is the location of this SNP on IL-6, and it's what's called an A to T polymorphism. So if you study, remember you get one part of DNA from your mom, one part from your dad, because it's a double helix. Most of the population in us, Europeans, Caucasian Europeans, would get 2 A's from their dad. So if I genotype most of the people in this room for this location, you would be AA, all right? Some people get an A from their mom and a T from their dad. So they'd be AT, they'd be heterozygous, all right? And some people, very small percentage in the case of this gene, or this polymorphism, excuse me, would be TT. They would be rare homozygotes. Okay, everybody got that? Mm-hmm. So common homozygotes would be AA, ATs would be heterozygotes, and TTs would be rare homozygotes. When you do genetic analyses, you're interested in doses of the rare allele. So AA people have 0, AT people have 1, and TT people have 2. You need to know that to be able to interpret the data I'm going to show you in just a second. Now, this got to be a little crazy making. So now the way that they're coding locations on a gene is through what's called a reference sequence. Right? RS stands for reference sequence. And if you plug this into the SNP database on PubMed, this is the location for this polymorphism. Okay? You get both. Okay. Okay. So here's the framework. It was patients who underwent RT, as I said before, and their family caregivers. We got the patients prior to the initiation of RT, which is when we drew their blood for the genetic analyses. We studied them weekly. Imagine doing this, people filling out a booklet like that big every week. And then every 2 weeks for 2 months, and then out an additional 2 months for 6 months. So this is a really robust data set in terms of a lot of data. What I'm going to show you today is the fatigue data. Oops. And as I said before, we did morning and evening fatigue. Okay, so this was a candidate gene study. We did a lot of SNPs. So I'm just going to show you the data on one of them right now, this IL6 gene. You have ways that you can combine data when you do a genetic analysis. There's an additive model where you would test each of these independently in relationship to your outcome. For this study, we decided because of the way they were proportioned, we didn't have that many people with a TT phenotype. It's permissible to combine 1 or 2 doses of the rare allele in the analysis. So we had 2 groups, all right? It's called a dominant model. What I'm going to show you is, did this polymorphism predict mean fatigue scores over the whole study, which I don't like to do, but which the literature does. Add them up over the whole 6 months, or did it predict change over time, which is much more interesting. So there was no difference in morning and evening fatigue scores between the patients and the caregivers. To do the evaluation of the contribution of that SNP to mean scores, we did linear regression. The slicker analysis over time, which is the one I want you to pay attention to, is this hierarchical linear model. Okay? This is a really slick analysis. So when you do prediction of mean fatigue, you try to explain variance, right? Simple process, really reasonable. These are putrid predictions, okay? And I should tell you, when you do a molecular analysis, and it was done with this, I didn't show you the data, you have to control for self-reported race and ethnicity, because our SNPs distribution vary by race and ethnicity, but you also have to control for known markers of ancestry in the population, and it's called ancestry informative markers. So we did that. I didn't show you. It's a relatively small contribution, but you have to make sure you control for that. Otherwise, you could get spurious results that may be based on race. So we got a little more variance. We got about the same variance for both of them. Look at that. But look at the predictors were different. Ageable was the only one we tested that contributed. In the evening, it was age and gender. All right. Would you like to guess directionality? Because I'm not showing the results of the regression. I'm only showing you the explained variance. Who had more fatigue, older or younger? Margaret, you shut up because you've heard the data.
Inverse.
Younger patients. All of our studies, younger patients do worse. We could talk about why that is later. How about gender? You only get 2 choices. You got a 50-50 chance here.
I was wrong before.
Women. Back to that neuropathy thing. Remember, Bob got saved here. And I don't know if it's biology or if it's a whole bunch of other stuff, but we're going to try to sort some of that out. We've been trying. We have been really, really trying. This looks really putrid in terms of the genotype contribution. That's actually a very good score. About 2 to 3% of explained variance is pretty good for the genotype. So, okay. All right, so here's the data. All right. So I said we were going to look at no doses of the rare allele compared to 1 or 2 doses of the rare allele. And we just looked at mean evening, mean morning. I didn't tell you because I'm not going to show you all the data, but we looked at sleep too. All right. So, is the T allele protective or deleterious? Because that's when you have to look at the rare allele. Who has more fatigue? The AAs, yes. So the T allele in this scenario is protective. Is a protective allele. Now, does that mean anything? What do you do with that data? I'll come back to that in just a second. Okay. All right. So let me show you the same data, but now we're going to look at the longitudinal stuff. All right. So this technique is called hierarchical linear modeling. And let me, without all the fancy math, because I don't understand all the fancy math, I have statisticians help me with this. Think about it as regression over time. And the cool thing about this technique, in comparison to analysis of variance, is you can have missing data in the dependent variable. Patty's shaking her head. So remember, with analysis of variance, if you're missing one data point, everything drops to the lowest number of participants. This is an inferential technique, so it infers the data. So it's really, really cool. You cannot have any missing data in the predictors. All right, so sometimes you have to impute things, or you lower your sample size for that, or you drop some predictors. We've had to do that, like income. Not everybody tells us that, so we sometimes take that out. So what you do first is you figure out the shape of the curve. That's basically what level 1 is. Figure out the shape of the curve. Is it linear? Is it quadratic? Is it cubic? We've had piecewise models with our chemotherapy data. You just have to do some sophisticated modeling to get that right. And then you get to go in and you say, I've got my favorite list of predictors. I've got demographic characteristics. I've got clinical characteristics. Can I predict where people start? That's the intercept. What characteristics predict the intercept? And importantly, what characteristics predict the change over time? So it's baseline characteristics. And the reason I like this technique is if you're thinking about it as risk profiling, right? In this case, if we measure people prior to radiation and we know their risk factors, we can say this is what your fatigue score is going to look like. Because what happens with this is you basically get a regression equation. And you can plug in all the characteristics and get a picture. Okay. All right. So this is what morning and evening fatigue look like across our study. And these are pretty standard curves. They go up. This is radiation. Okay. They go up and then they start to come down. But that is boring as hell. boring. And is what's in most fatigue studies that have been published, right? But here's the point. Yep. That's the evening fatigue scores of that whole sample, about 250 people. That's just for the aficionados in the room. That's called a spaghetti plot. That, okay, I often say, is not that. But that's what we've been publishing. All right. And then the statistician just took out, I think that's a random sample of about 15 or 20. So you can kind of see, I mean, here's this person. I don't need to interact with that person. You know, and they didn't fill out the book backwards. I can tell you, because there's other variability in their book. So they just didn't go down the 0 column on the scale. But these people, we got to figure out what's going on with them. I mean, oh my God. And they look different for morning and evening. Okay. So here's the data. Here's the same polymorphism for evening fatigue. We just used it as a predictor. It did not predict the slope. It only predicted where people would start, which is a good thing, probably, because you want your genetic markers to begin to predict who's different between the two groups. And we got the same trajectory. So if you were if you had 1 or 2 doses of the rare allele, the T allele, you had lower fatigue. You started with lower and they stayed lower over time. Okay? Now we published, I'm not going to show you, I don't think I put into this next. Oh, I'm hitting the wrong button. Oh, that's morning. I just showed you the same day. So I'm not going to show you, we did all the phenotypic predictors, it's in the published papers. But what's cool about this is that this was the first study to show that this polymorphism was associated with morning and evening fatigue. We calculated the effect size. So not just was it a statistically significant association, but it didn't have any clinical meaning. And you can see pretty good for a small sample, pilot, pretty good. But what's more exciting was this is our SNP. We couldn't find an experiment that showed any functional activity for that SNP. But there was a paper that was published for this SNP, different location, 6331 T to C polymorphism, that showed the carriers who were homozygous for the common allele, so just like our patients were for the common allele had higher levels of fatigue. They showed that for 6631, carriers who were homozygous for the common allele had higher levels of IL-6. Now, they didn't measure fatigue, right? But higher levels of IL-6 in other cancer studies have been shown to be associated with higher levels of fatigue. Now, the part that's cool about this is our SNP is in linkage disequilibrium with the SNP that's shown to have a functional effect. Now, what the hell does linkage disequilibrium mean? It means they're proxies for each other. All right, they most like that. Our SNP most likely has a similar biological function. So that's really cool. That's really cool. And that you have to get from the literature. We didn't know that going into the experiment. All right. All right.
You're good.
How are we doing?
You're good. We'll leave a little time for questions, about 3 minutes, and then 3 to 5 minutes, and then we do questions. That way we give people.
Any questions?
Take a break from talking.
Yeah.
I'm relieved because Marilyn had given me data from your exercise study, and I uploaded it to Dropbox before I heard Chris's talk. And I uploaded it, and I said, well, no, we have to do the hierarchical model on the small study. So I uploaded 85 files last week with your same analysis approach. And I'm like, yes, because we didn't talk to Chris yet. I said, well, that's this way I do it. So
yeah, good, great, yeah.
Because now I'm going to give you the link to Dropbox.
Good. Now she can give me the link. It's a very, yeah, please.
You had a slide earlier with sleep. So what was the relationship, I suppose, with the biomarkers, and was sleep constant, or did sleep vary, or?
It looked exactly like that spaghetti plot. Yeah. Yeah, and I'm trying to remember, we did do this SNP also, I believe, predicted the trajectories. If I had plotted this for sleep, we would have seen the same thing. It was protected. So people who were not this slide, sorry. This slide. All right, so people who were who had 1 or 2 doses of the rare T allele in this case would have a worse sleep disturbance score. Yeah.
You know how a person can have an influence on someone's pain by saying, oh, this is really going to help you, blah, blah, blah. Do you think the same thing could happen with fatigue? Like, how much fatigue am I going to get? It's like, oh, you'll get just a tiny bit of fatigue. Do you think that could influence a person?
Not in clinical.
Because the mind-body connection
and or anything else.
I mean, part of the issue is I don't think we know biologically by you saying to me you're going to have a little bit of fatigue or a little bit of sleep disturbance, what's going on.
Right.
It's not influencing this.
Yeah.
Okay, because this is the hard one.
Right, right.
Can it influence your expression?
Right. So, I mean, we're so complex that I wonder if things like that could influence.
Well, that's a testable hypothesis.
Yeah.
You can do an experiment and look at biomarkers and see if they go down. I think there's been some work like in meditation and looking at these markers.
Yes.
Yeah. So certainly that's a testable hypothesis. Yeah.
So yeah, I was kind of interested in the point that you made earlier about this is really way out of
no, go ahead. Yeah, that's okay.
About the younger versus the older patients and their fatigue. And so is there kind of like an expectation aspect to their self-reports of fatigue, where if you're younger, perhaps you're expecting yourself to feel more energetic, and therefore, feeling fatigue has a different meaning, or you see it in a different way, whereas maybe if you're older, you're kind of expecting yourself to start out differently, and so you might not react to it in the same way?
So where the work has been done on that is in quality of life, in cancer primarily. And the phenomenon is called a response shift, where it was expected as people's trajectory of quality of life got worse by our standard as their disease progressed, we would see worse quality of life scores, and in the elderly they didn't. So there's a whole literature about response shift. I can tell you that's what we've written in these papers. I'm not sure it's all true. Right? And part of the reason I don't think it's all true is I think we haven't done good measures of other factors. So one of the things we've added to our studies, and sometimes it predicts, sometimes it doesn't, but it's worth, I believe, evaluating in symptom studies, is childcare responsibility.
It's not, it's
Yeah,
interesting
yeah,
to
yeah.
say that because I was going to ask about kind of the larger social context as to what other kind of support,
Yeah.
Right.
you know,
Yeah.
and so forth.
Yeah.
But the response shift piece, so that's very active in the developmental disabilities.
Oh, right.
as
Okay.
well, right?
Okay.
Where,
Mhm.
you know, clinicians think this
Yeah.
is going to be awful,
Yeah.
but the family caregivers and the individuals themselves see their quality of life as more positive than others might expect it to be.
I think, you know, we've had a lot of pushback. I can tell you the other things that play into symptom burden, which you might want to consider that we haven't talked about. One is functional status, right? And in oncology, there's a very classic single item measure. It's called the Karnofsky Performance Status Scale. It goes from 0, which is dead, to 100, which is fully functional. It predicts everything. This single item scale, you know, we have your point. We have patients fill it out, because the doctors overestimate Karnofsky, all right? And we only go to 30 usually on our studies. We don't like dead on the scale. Patients wouldn't like that. The other thing we do a good job in understanding is comorbidities. And whether you count the number the patient has or you use a comorbidity scale, we use one called the self-administered comorbidity scale. It's got good validity with the Charlson, which is a very labor-intensive chart review measure. Works really, really well. Very predictive. What else do we? You know, co-occurring symptoms, depression, anxiety, they all influence each other in terms of the experience. And I'm becoming more and more convinced, I was talking about this on Tuesday night, that we need to study stress.
Yeah.
And what we've been looking at, we've been looking at perceived stress, so at the time, we use the perceived stress scale. We've been looking at we've been using the impact of event scale revised. And the reason we like that is you can make that one disease specific. So we ask about cancer and its treatment, but you could use it for heart failure and its treatment, that type of thing. And it has a measure of PTSD, which we really, really like. And then the third one we've been using is called the Life Stressor Checklist Revised. And that's a little bit of a, what I would say. It's not an easy instrument to give to people. The IRB gets crazy with it because you ask about pretty personal stressors, not just have you been in a car accident, have you had a serious illness. You ask about were you sexually abused, were you physically abused before or after the age of 16. But I'm telling you, it's predicting a lot of our symptom burden in patients. And we've given it to patients in our cancer milieu who have said to us, I'm so happy you are asking me these questions because I believe stress has caused my cancer. So it's going to be one of the measures we add to if we get the $23 million study. You were first, then we'll go back. Yeah.
Yeah, the questions that were being asked about almost like a before and after, where I was thinking to myself of Sister Krista has a thing in her theory about self-consistency and self-ideal in the self-concept.
Okay.
And it seems to me valuable to look at the self-consistency that people have before and after they have these diagnoses and where the fatigue is. Because if the issue is, are you how you normally would be? Or if the issue is, are you functioning the way you normally would expect yourself to be? And then what is your self-ideal? Because, you know, people with cancer could come in as couch potatoes, but they could come in as, you know, high-level executives. So the expectations are so different.
Is there a scale to measure that?
Sister has a few.
Oh, we'll have to look at that. Thank you for sharing that.
Yeah, I'll ask and I'll try to find out about that.
So that's a good point. Very good point.
Oh yes, I just wanted to ask if other than self-reported measures, are there other measures, especially if you're talking about stress and pain, you know, we're talking physiological, vital signs, maybe cortisol levels, blood levels, you know, things like that.
Yes. So for sleep, we've done actigraphy, you know, a little wristwatchy gizmo. And self-report of sleep disturbance does not correlate with actigraphy. And that's true in other things. For our neuropathy studies, we use a lot of measures. We use sensation measures with monofilament testing. We do loss of pain, loss of cold sensation. We do grip strength. We do a balance measure. Sometimes they correlate, sometimes they don't. Cortisol is a pain in the butt to do. Okay. If you want to do acute cortisol, it's spit, and it's got a diurnal variability where you have to measure it, I think, 3 times in the morning and then at night. If you want to study chronic stress, Cortisol is a good measure. And you know where you get it from? Here. Okay? And it's a very, very robust measure. If you start it, you don't want the follicle. You want right at the base of the skull. And about 3 millimeters is 3 months of stress.
Is that why
There's some issues around hair color and hair dye. No offense, Bob. Yeah. The biomarkers, all these cytokines, the reason we haven't measured them in the serum, most of them have a diurnal variability. So it's a real pain to do. Real pain to do.
I'm sorry, one more question.
No, go ahead.
You've studied so many symptoms related to cancer, et cetera. Have you thought about cancer brain?
Oh, chemo fog?
Chemo brain.
Yeah. It's not chemo brain anymore.
Okay.
It's
what's the
now
word?
cancer-related cognitive impairment. All right, because it's been shown that people walking into cancer get it, people with radiation get it. I think family caregivers actually get it too, related to the stress. What we've done by self-report is that attentional function index I talked about.
Okay, yes.
If you're interested, there are other ones.
Okay.
In the hearing study, we're doing an iPad game because the attentional function index is largely executive function. It's not all the other tests.
Right. So
We've had doctoral students do the trail making, the serial sevens, all that stuff. Does not correlate with self-report.
Okay.
All right. I'm working with a group in our neuroscience institute and we can't get the STEM grant funded. It's like, it's torture, absolute torture. But it's to test a game, a neurocognitive game. And there we're going to use EEG. We'll do some self-report, but we're going to study it with EEG. And we just got the grant back. They said, why aren't you doing functional MRI? Well, do you know how much expense it costs to do a functional MRI?
Sure.
I don't want to do functional MRI. What good is that? So,
right.
Yeah. So if this game or if this it's called a TabCat. It's a series of measures of cognition. Patients don't like it. All right. I think it's because they're stressed out a little bit about it. What is this really telling me?
Yeah,
Am I really stupid? Have I lost function? That type of thing. So we're going to see how it pans out. They've used it more. We're borrowing it from our neuroscience group. They've used it more with dementia people.
Yeah.
Maybe they don't care as much. I don't know.
No, they
But-
get stressed.
Yeah. So have you used
My
it?
sister,
Yeah.
I'm thinking of my sister,
Yeah.
how stressed
So,
taking any test.
but most of the objective measures don't correlate with self-report.
Okay.
And my own hypothesis is it's probably different areas of the brain. We probably need to look at the two together to see what's going on. Yeah. Or there's got to be some threshold of change that occurs before you see a sign rather than a symptom.
Right.
Now I'm gonna be a
Thank
little
you.
bit pushy here, not on time, but I want to make sure there's another question in the room.
Anybody on the?
There's another question in the room, and I want Angela, Beth, Felicitas, Lisa, and Shirley. If you have any questions, unmute your mics while Pat Donnie Porter asks her question for now. Thank you.
Chris, earlier you said that theoretical frameworks are your favorite.
They're not my thing.
So Dr. Hannah and I both presented last week at the annual Theory Nursing Conference.
Yay!
It was a celebration of 50 years of nursing theory. And sometimes I think we have some artificial divisions there, where the people who are most interested in nursing theory think that, and are concerned, certainly importantly so, about the unifying focus of the discipline and how we're moving forward. But to me today, when I look at this, it's absolutely breathtaking what you've contributed to caring, symptom science, and the way that you've brought us through this progression of intense care for what is happening to the suffering human being. Have you ever thought about looking at something in terms of all your multiple contributions and your team to caring science and framing it that way at all? Or could you speak to us a little bit?
We use the theory of symptom management. We use the theory of symptom management. And I don't mean to belittle theory. And I'm a physiologist, right? So I'm often using a physiological theory.
Exactly.
There's times, though, and I'm trying to think of a good example where we've tried to write a theory, and We were forcing a theory to fit a graph.
Yeah.
And that makes me crazy. It makes me crazy. You know, or we'll write the symptom management model. Oh, we really don't like that. Blah, blah, blah. Why didn't you use such and such? I mean, for the pro-self study, we use self-care. We use Orum's theory. So I'm not theoryless, all right?
No, I think you're not theoryless.
I know.
You're beyond it.
You're beyond that,
Yeah.
and in a way, there has to be some kind of conversation. Deborah, do you feel that way after what we've just been through for a few days? This is
I think what we were talking about last week was the authentic theoretical thinking rather than pseudo-nursing thinking.
Right.
And pseudo-nursing thinking is almost like some kind of obedient thinking to the system that you're in and being confident on the floor and that kind of thing. But authentic theoretical thinking, the way we were conceiving it and talking about it, had to do with the nurse's creative ability in the moment to see what's going on with the patient and to respond. And the theoretical thinking that we've all read about is kind of what informs us in a way as to which pathway we're going to take to look. So when you were talking about this, I'm a Royce scholar, so I understood Sister's theory in that aspect of the self-consistency and self-ideal. And this is actually, I mean, to me, this is very, very interesting because it could fit in very nicely with a lot of Sister's underlying philosophical assumptions and her theoretical propositions. And I think that, you know, over the years, she's kind of looked at the research with her theory in order to understand if her theory is valid and if it's useful. And repeatedly, it shows that it is because it's basically about stress adaptation and coping, which is what you're
Absolutely.
As we go full circle and around.
So this is really the most authentic theoretical thinking about nursing from this kind of a quantitative research perspective. That is just so beautiful.
The other thing when I was reflecting on giving this talk at Rockefeller on Tuesday was, you know, it goes back to Florence, right? And nursing is really about the whole person and the individual. You know, and I did those slides at the beginning with a purpose. My trajectory started with an individual who happens to be my dad. And we've done a lot of collective stuff, and now we're back to the individual. And that's why nursing has to be at the table. You know, all of these precision health initiatives, I'm glad the language has changed from precision medicine. If you look at those diagrams, it's nursing. And there's going to be so many opportunities for us. I'll just give you one more example. This group in the UK that does the traffic lights, they are engineers, all right? And they're working with a group of clinicians who are studying the elderly. And these engineers are making sensors. And because they can study motion and movement, they put sensors into these old people's homes in the UK, and they put one on the refrigerator door. They put one in the bathroom. They put one on the staircase, one on the person's chair, one on the bed. And in a pilot, just based on changes in movement, they diagnosed 6 urinary tract infections. Okay, nursing needs to be at the table with these engineers. You know, we've got these people at Lawrence Livermore Lab in Berkeley. They know how to make widgets. They have no idea what kind of widget to make. We have to go over there and say, we've got this problem. I don't know how to analyze motion data, but by and God, I want to study it in our people who have neuropathy to see if we can figure out falls going up and down the staircase. That's what we need to do. We need to be in those conversations. The time, I wish I was 40 years younger, because the time, all these young people are getting their P.hD. I mean, the time is right to do this now. It's never been better.
And just to echo what Chris is saying, a group from Stony Brook, the nurses there, we were thinking there was a competitive grant going on campus that only one group could put in, and it was a Smart and Connected Communities NSF grant. You know, so I was talking with a colleague about it. I'm like, where does nursing fit with this? Let's just go over to that meeting and talk about that. And so we were just talking about, we were doing some aging in place in suburbia work. And we were talking about that. And so kind of after the initial discussion, one of the people from the engineering department of computational science came over, latched onto us like glue. And he said to us, I am so happy to meet you. We have the solutions, we don't have the problems.
Absolutely.
And that birthed into this kind of a germination team that we're looking at some of the things that your UK group is looking at. And I will just never forget one of the topics we were talking about. And so our engineer and our computational scientists and then myself and my colleague were in the room, and they're talking about censoring people and censoring rooms and doing this, and they're talking about, and then we could put a drone and we'll fly a drone. And my colleague and I were walking back to our part of campus, and we started laughing at, oh, they're so funny, those engineers. Putting a drone in a room, and then we went back to the next meeting, and they're like, okay, so when we do the drone, talking about infrared because of protecting identity and all of that, and we were like, oh, the drone's a serious consideration.
I mean, we were talking about teaching people how to exercise. Well, they can track them on their phone.
Yeah.
They just have to put a little app on their
Yeah.
phone with consent. I mean,
nurses need to be at this
they
table.
absolutely have to be at these things. I was at a meeting with General Electric. They were thinking about these things too, and they were looking at, in a acute care setting, trying to visualize pain in people who couldn't self-report. This got me a little scary because they were reading facial expressions based on work they had done for the CIA on who was lying. Okay, they had patterns that they could differentiate people who were lying or not lying, and they thought they could use that visual technology to figure out pain, no pain. We got to be at those tables, not only for the discovery, but the ethics.
Yes.
I think that's a great way for a thematic close, but I want to make sure, except Aaliyah left. Oh no! But the promising on how do you manage your time, because I'm going to end with a question, and you guys out there, thank you very much out in the hinterland, but no one's clicked in, so I'm going to move and close this so we can all get some lunch and relax the afternoon. I hope, Chris, thank you for your time. This is great. But before you leave, I want you to give us any kind of pointer that you can give in sort of the not the TED Talk, but maybe the Twitter feed on how in the world do you manage your time?
Well, a couple of things. One, I only have to be in the office 3 days a week. And that's when our
Did our dean hear that?
That's what we do. So Monday and Friday, Monday and Friday, I do a lot of writing at home. I use a lot of things over and over again. When you're beginning, I think it's really hard to write your first grant, get the language right. But when you're writing multiple grants, multiple studies, the language, uses itself. I take advantage of collaborations. I have more data than God. Okay. Oh, and can I do one more thing before we go? I have to give you my Catholic guilt slide. Skip ahead.
And I'm going to close this so you can see it.
I like to write. Okay. So here's the guilt slide. If you need to I have this over my door, and I'm going to read it to you, and over my desk. The crunch comes when the work has to be written up properly and presented for peer review. Most researchers find writing difficult, tedious, and frustrating. There is, however, no point in doing research unless it is communicated. It is otherwise a waste of resources and time and becomes an entirely selfish, parasitic pursuit, playing games at somebody else's expense. Okay, I'm sure Ronnie will print this off for everybody who wants one. Right? I mean, if you don't disseminate your research, you're not going to get funded again. That's the reality. And so building your own, word library that you can cut and paste. The journals that make me crazy, I just had this happen last week. For me, the methods are the methods. They're the recipe. And if I get an $8 million grant, I'm not going to write one paper. All right? How many times can you rewrite the methods? And this one journal said, you have gone over our limit of 50% of the content saying the same thing.
Thank you for saying that, yes. Yes. In fact, how many
times can I rewrite the methods when I've written 30 papers on the same study? Drives me crazy. So anybody in an editor position, if that can be changed.
Be more flexible and accept what a lot of, I think a lot of other disciplines do, which is to say to publish the methods already in paper.
Oh, we do that, but they do this, they do the counts and they say it's 50% over the blah, blah, blah. So I went in and changed every other word in the methods yesterday when I was waiting for Bob to go to lunch. And he's like, okay, you want to play this game? But then it looks stupid. And somebody's reading this and saying, is this from the same study as this? And the only way you can tell is the grant number. So reusing a lot of things is really, really sharing.
Yeah.
You know, there's no reason to reinvent the wheel. I give people my grant templates all the time.
Yeah.
It's, you know, it's.
And it's okay to ask.
Yeah, I mean.
I think as novices say, oh, I couldn't do that. Why not?
And once you get a
can say, "Here is no."
database, you know, most of my students do not do their own data collection anymore because we've just got so much data. So they work on our studies because we have studies that are running all the time, learn how to be scientists, they write their proposal, they carve out a unique piece. I did not care about nausea or vomiting in one of our studies. I had a student that loved it. She's going to build her whole career now on the microbiome because we have evidence to show the microbiome is disrupted with chemotherapy induced nausea. Am I going to study that? Nope. I have no interest in doing that. But once you build a critical set of data, you can collaborate together. That's the other thing we do.
And then bring really important people from the other side of the country who can come up. Chris, I have to thank you for
thank
this.
you. Thank you so much. It was delightful to be home.
We'll be here a little bit longer. For you guys on the outside, I can't help you to be here at this point, but we're going to be here a little bit longer.